Good day, everyone. I'm Dr. John Ward, Director of the Coalition for Global Hepatitis Elimination here at the Task Force for Global Health. We're located in Atlanta, Georgia. It's my pleasure to be convening this um, uh, next edition of our webinar series on hepatitis elimination, where we'll be looking at bringing hepatitis B and hepatitis C screening to communities in the United States using a variety of different strategies that are appropriate for those communities so that the testing and treatment for hepatitis B and hepatitis C is available to them. I want to thank Roche for sponsoring this webinar today. Next slide, please. Just thank you all. As I mentioned, we are the Coalition for Global Hepatitis Elimination. We have almost 70 webinars now looking at various aspects of hepatitis elimination that are available on our website, globalhep.org. This is our standard webinar series, whereby, as you'll be hearing from in a moment, it's a great opportunity to hear directly from people doing the work to make prevention, testing, and treatment available so that people's health are protected or improved. And in so doing, we are reaching goals for hepatitis elimination. So in the format, you'll be hearing from our presenters here in a few moments. You'll have an opportunity to submit questions in the QA feature of Zoom. I'll ask the speakers to respond to questions of about particular aspects of their talks for clarification, et cetera, while seeking to capture those questions for discussions later on in the program. All the webinars are recorded in full and are available on our website. There will also be individual presentations that you can look at, as well as all the slide presentations. The speaker bios and other resources are available there, just in the interest of time, so that we can provide the maximum time to hear from the speakers. And then I encourage you to sign up for our newsletter while you're there, so you can get information as early as possible about other webinars that we'll be hosting and other resources that can be helpful to you. Next slide. Again, this just shows you the type of information available and how you can access it on our website. So today we have a great collection of presentations. I want to thank right up front all the speakers for sharing their experiences. As you'll be hearing from our colleagues in Colorado, New York, Missouri, South Carolina, and Arizona about the different strategies that they're putting in place to reach populations that are often at highest risk for hepatitis B and hepatitis C, while at the same time being the most marginalized, being among the most marginalized in receiving routine, preventive, and clinical care services. And we're going to see how we can overcome those gaps so that we can prevent and detect and treat hepatitis B and hepatitis C. So without further ado, let's go to the next slide, and I can introduce Mariah Frank, the Prevention Director of the Boulder County AIDS Project in Colorado. Mariah, thank you for joining us.
Thank you so much for having me. I will go ahead and share my slides so everybody can see. Awesome. Okay. So I'll go ahead and get started. Again, just being mindful of everyone's time. My name is Mariah Frank. I'm the Prevention Director at the Boulder County AIDS Project in Boulder, Colorado. And I'm going to be talking with y'all today about how we're integrating hepatitis C screening into our harm reduction services in Boulder County. So first, I wanted to give a really quick overview of the Boulder County AIDS Project. The long story, really short, is that the Boulder County AIDS Project, or BCAP, is a nonprofit HIV services organization that serves a 4-county region in Colorado. We serve Boulder, Broomfield, Gilpin, and Clear Creek counties. And for folks less familiar with Colorado geography, we really serve an area of Colorado, sort of northwestern Colorado Front Range. So we're a little bit northwest in the state, and we serve a region right up along the foothills of the Rocky Mountains and a couple of our mountain communities. We are an HIV care and HIV prevention services organization that has been here in Boulder doing HIV services work since 1985. In 2008, the HIV hepatitis C syndemic led us to incorporating hepatitis C education and testing into our services. And then again, we expanded in 2013 to include harm reduction services, which includes our syringe access program that serves people who use and inject drugs and people experiencing homelessness, with the knowledge that things like sharing injection equipment, sharing equipment for substance use can increase the likelihood of an exposure to HIV or hepatitis C. We began really dovetailing in our free testing service into our harm reduction programming. So we do offer free testing for HIV, hepatitis C, syphilis, chlamydia, and gonorrhea through our harm reduction programming here at the Boulder County AIDS Project. Our prevention team is a team of 4 coordinators and myself, and we have 2 coordinators who are really specialized in our harm reduction and prevention services, one of whom is bilingual. Spanish language capacity is really important to us here in Colorado, and so we do ensure that we have bilingual capacity to offer these services as well. So that's a really quick overview on us. But I wanted to jump in to the programming in which we are integrating hepatitis C screening, testing, linkage to care and treatment into these harm reduction services. So I've broken this down into 3 topics: our point of care rapid testing, what our linkage to care options look like for our participants who access our services, and then how we go about utilizing incentives to keep people engaged in this programming all the way through the end of treatment. So first is a brief overview on our point of care rapid testing. We utilize for our rapid testing the OraQuick hepatitis C antibody test. That is the 20-minute rapid test that is done via finger stick. We feel really fortunate. All of our rapid testing that we do here is all off of finger stick for HIV, hepatitis C, and syphilis. So when folks come in to access this service, we can use a single finger stick to test them for a number of different things. And importantly, we incorporate this hepatitis C screening into a broader context of utilizing a counseling, testing, and referral framework. So if someone comes in for a point of care rapid test, the test takes 20 minutes, but we do spend a slightly longer period of time with folks discussing various aspects of their physical health, social health, behavioral health, things like their substance use, their mental health, any potential exposure to domestic violence, their experience of houselessness, insurance status, a whole range of factors. And then if they are accessing or wanting to access services that we do not offer in-house here at BCAP, we do what we can to make those active referrals, warm handoffs, and connections to any variety of different resources that they're wanting to access. I'm going to take a quick pause because I have the chat is over on my other screen, and I want to see if any of these are related to me. They're not. Great. So that's the quick overview of how we do our point of care and our rapid testing. The real, I think, meat of this is in our linkage to care options. So I did my best to create a real crude flow chart of what this looks like in PowerPoint. But essentially, if someone comes to us through our harm reduction services and they are wanting the point of care hepatitis C testing, we bring them in, we run that test for them. And if that test comes back reactive, our next step is to get that person a confirmatory test, because our antibody test is only telling us if they have ever been exposed to hepatitis C, not telling us if they have hepatitis C right now. So we give folks a number of options to access that confirmatory testing. One option is an in-house dried blood spot card technology. If folks haven't used the dried blood spot cards before, they're sort of a little index card. And there's 5 small circles on the card that we have to fill in with blood. We let that dry, send it to a lab. The lab runs the test through those dried blood spot cards. That's one option that we can immediately offer to folks upon receiving a reactive result. So in that same testing session, we can get them that confirmatory test. If for some reason folks don't want to access a dried blood spot card, we have 2 different options for blood draw. One is that we can refer them offsite to a clinic that we partner with that will do the blood draw. And if that confirmatory test comes back positive, reflex and start treatment. If offsite and trying to get to another clinic isn't the best option for folks, we also partner with the Denver Health Team, so much larger hospital down in Denver, and we partner with them. They come out once a week to BCAP during the hours that we operate our harm reduction services, and they can send a phlebotomist. So they send a phlebotomist, they can do blood draws here on site. That participant can also meet via telehealth with a doctor to discuss their blood draw. And then the phlebotomist takes the blood back to Denver to run the blood for confirmatory testing. The reason we have a lot of these different options is because although BCAP is a really wonderful space for folks to be an entry point into a lot of different care options, we do not have doctors or physicians on site. So we don't have phlebotomists on site. We cannot do the blood draws, prescribe the medications. So we really utilize a lot of really efficacious partnerships to make this work for folks. So someone's done their confirmatory testing and we need to get them into linkage to care, and because that came back positive, they also have options where they can either get testing through an offsite clinic that they may have gotten that blood draw at, or post dried blood spot card we have linked them to, or in the case where they have had their blood draw conducted by the Denver Health Team here on site, Denver Health will mail us their medication. And then they can come by BCAP, pick up their medication, and have that be a really easy access point to care. Lastly, something that we have found to be really successful in our effort in integrating hepatitis C treatment and linkage to care with our harm reduction services is meaningfully incentivizing clients through the testing process, the linkage to care process, and the treatment process to keep them engaged and not only incentivize, but compensate them for the time that it takes to get here to BCAP and to go through this process. So when we first started our incentive program, we made sure that our incentives were informed by what our clients were telling us they wanted. And so we have choice for folks. We often have gift cards to things like grocery stores and gas stations. We have tents and sleeping bags for clients who are experiencing homelessness and sleeping outside. We also sometimes have these really nice hiking backpacks so folks can have a place to store their stuff. And we do incentivize folks all along this continuum of care. So from rapid testing to confirmatory testing, starting their medication, finishing their medication, and coming back for those blood draws post finishing their medication, we get folks incentivized all along the way. So we are compensating them for their time and keeping them engaged in care. And we have found a lot of success in doing this. I know I am right up against my 10 minutes and I want to be mindful of time. Here's my contact information for anybody who would like it. And thank you so much for the time and space today and for hearing about our program here in Boulder.
Thank you so much, Mariah. That was a great overview. I know I have a few questions to ask you. I might put a few of those in the Q&A to get things going, and hopefully we'll have a chance for you to comment on those verbally as well as in writing. But to make sure we get it everyone's time honored, let's go to the next slide and hear from Dr. Sam Sigal, who's the director of hepatology at the NYU Langone Hospital in Long Island, and who's been working with community and faith-based communities to extend opportunities for hepatitis B testing and care. Sam, welcome. Thank you.
Thank you. I will run a little bit over. I apologize. So give me one minute. Okay, I'd like to thank you for this opportunity. Below are my disclosures. Hepatitis B is endemic in West Africa, has a prevalence of 10 to 15%, the number one cause of liver cancer. Unfortunately, there's limited screening, diagnosis, and treatment. There's been a dramatic increase in the West African community of the Bronx between 2015, 2019, over 46,000 individuals called Bronx home. In the 2020 census, 11% of non-citizens and 10.7% of naturalized citizens were from West Africa. Unfortunately, as in West Africa, there's limited screening, diagnosis, and treatment. For my remainder of my talk, I would like to describe the development of an hepatitis B outreach program to the Bronx West African community. It started as an educational program, but rapidly evolved to screening, vaccination, evaluation, and as well as general health measures. We developed the program based on an attempt to understand the community's perspective, and throughout my talk, I will highlight principles for a screening program based on our experience. So the first step in our program was a hypothesis that education and cultural sensitivity were key. And for this, working with a West African, Steve Boehner, who was a West African physician volunteer, we developed a PowerPoint presentation that started off as clinical vignettes important to the West African community, spoke about epidemiology, liver function, what hepatitis B was. We wanted a high level so that the patients, when they went to see their physician, they could actually participate in their discussion. So we went over what liver tests are, cirrhosis and complications, liver cancer and screening, treatment, vaccination, and then we reviewed the clinical vignettes to say how things could have turned out differently. So the first question that came up is how we're going to implement the presentation. You know, we were told about a very important meeting called the Bronx African Advisory Committee that meets in the first Thursday evening of every month. It's composed of the thought leaders of the African community. And we were cautioned saying that another program had approached them saying, we're interested in hepatitis B. And they were rapidly rebuffed saying, we're not interested in hepatitis B, we're interested in hypertension, please leave us alone. So we decided to take a different approach, a passive approach. So we started going to the meeting, and after 3 or 4 meetings, they turned to us and said, why are you guys here? And we said, well, we're from Montefiore, from the liver program, and hepatitis B is very common in West Africa. And they said, do you want to give us a presentation? So the next month, Steve gave the presentation. It was extremely well received. And they said, how can we help you? And we said, well, we like to have introductions into the community. So, and they rapidly said, these are the names. So this highlights the first principle. You have to engage the community and its leadership. So Steve, using those names as well as making cold calls, he contacted religious leaders at local churches and mosques to arrange a meeting, at which time he reviewed the importance of hepatitis B to the West African community. They would decide upon a date for the educational event after religious services. It was advertised through bulletins, social media. And then Steve would come back and I said, Steve, how did it go? He said, it was great. The presentation about 30 minutes, and then there was a 30 to 60-minute question and answer session. And I said, we really need to capture this enthusiasm. So we developed a very simple 6-question post-presentation questionnaire to assess the impact. So we summarized our first 62 respondents, and Steve presented it at the 5th Annual United States Conference on African Immigrant Health. And of 62 respondents, 9.7% indicated previous screening. Everyone said they had improved knowledge. They were more willing to talk about it, change an attitude, talk about family and friends getting screening. So this highlights principles 2 and 3, education and cultural sensitivity. Now, we were very frustrated. We had developed motivation for testing, but we couldn't follow through with actual testing. For this, we required funds for serologies and official personnel. So for this, we required a couple grants, a little philanthropy, and importantly, we received a New York City Council grant for hepatitis B navigator. So the design of the program was to organize an event. We would count how many patients were actually attending the event, how many completed the questionnaire, how many requested testing. We would get their telephone numbers. We'd take it back to my secretary, who would create medical record numbers and schedule events. We'd see actually how many showed up. And at the screening visit, we completed a brief questionnaire, did a blood pressure check, and obtained serologies. Now, we met immediate roadblocks. So calls were not answered. Or if the person would answer the phone, hear my secretary, they would immediately hang up. Demographics provided were frequently incorrect. Usually the birth dates were off. There were frequent no-shows. My physician volunteer left for medical residency. There was a prolonged HR process for hire, and I was convinced that the game was over. So the very first person I interviewed for the position was Fatima Omarfulu. And in retrospect, I probably was a little bit rude in my interview. She walked in. I don't think I even let her sit down. I said, Fatima, what are you currently doing? She said she's a CCU patient care technician doing EKGs and blood pressure checks. And I said, do you know anything about hepatitis B? And she said, no. And I said, do you know anything about West Africa? She said, yes. And I said, do you feel comfortable in talking in public? And she said, yes. So I said, great. Here's my presentation. I'm going to leave for 5 minutes. I'm going to come back. I want you to give it to me. So I come back in 5 minutes. She starts giving me the first 5 slides. And I said, you're hired. And immediately all my roadblocks disappeared. She used a cell phone rather than a hospital phone. So when the incoming call came in, they saw this personal number, not Montefiore. So they answered the phone. They heard her voice. They started talking with her. They didn't hang up. And they gave the correct demographic information. And most importantly, they showed for appointments. So in this slide, I reviewed the outcome for our first 9 educational events involving 550 individuals. 2/3 completed the questionnaire, gave us the exact same information as in our first study. 60% requested testing. 2/3 actually showed for testing. Now, you have to realize this is rather spectacular. So we're screening an immigrant population, usually not affiliated with the U.S. healthcare system, for a stigmatized condition, and they're coming in for testing. Why was it so successful? Well, I like to propose that the reasons were trust and respect. So trust is a major issue in screening a vulnerable population who's not familiar with the U.S. healthcare system, especially for a stigmatized condition. And actually, they actually had the concern about experimentation. And we actually experienced that. After the first couple patients were screened, they came back to us and said, you're doing research on our blood. And we said, what do you mean we're doing research on the blood? We said, in the presentation, you said you would draw 1 tube of blood. You're drawing 2. The second one you're using for research. And it turned out that there were different labs who did the antibody and the antigen. For ease, they did 2 tubes of blood. So we had to correct our presentation. Many people who showed up turned to Fatima and said, I'm only here because I trust you. You're from West Africa. And also we had the support of their religious leaders, which is extremely important. Respect is very important. Fatima just didn't show up at the mosque and say, I want a presentation. She would actually go to religious services for a couple of weeks. So she would see who was there, who were the leaders. They would see her, feel comfortable with her. At the time of the presentation, it was very punctual. We provided refreshments. Even the Montefiore guards actually played a role. So this is the middle of COVID regulations. So for people to get into the hospital, they would have to stand in line for hours, and they would be fighting in line. Fatima made an arrangement with the guards that when the person showed up, they would call her. She would come downstairs, grab them by the arm, and take them right past the guards. People said they felt like they were VIPs, that they would just bypass the line. So the next steps I would like to briefly review would be vaccination, the evaluation of hepatitis B positive individuals, which unfortunately I do not have time for, and hypertension. So hepatitis B vaccination rates are very low in West Africa. In a random survey of Nigeria, only 31% knew of the vaccine availability, and only 21% actually received the first dose. This is unfortunate in that HPV vaccination programs in other endemic areas, such as Taiwan, have been shown to be extremely successful at decreasing rates of cirrhosis and liver cancer. So vaccination compliance in immigrant communities is low, regardless of the vaccine type, whether it's pneumonia, tetanus, papillomavirus. Compliance with the multi-dose series for hepatitis B is low. Only about 30% of US individuals have been vaccinated. And if you look at studies that have looked at the compliance rates, 44% for the 3-dose series, 60% for the 2-dose series, you combine these two roadblocks and you have dismal vaccination rates. So in the Vietnamese community, in the survey, only 7% were vaccinated. And in the survey of 919 West Africans in New York City, only 10.9% had evidence of vaccination. So here we're screening an at-risk population. We're identifying individuals at risk, and we're recommending vaccination to individuals with possible limited capacity to adhere. So to address this issue, I was the recipient of a charitable drive in 2020 for $8,000. And I said, I'm going to take all this money and provide free vaccine to everybody who needed it, regardless of insurance status. So beginning January 2021, everyone screened who lacked the antibody was vaccinated. And then we did a look back at those who have been screened between 2018 and 2020. And we contacted them and said, have you been vaccinated? If not, come in and we'll vaccinate you. We had the program was extremely well received, very high compliance rate. People would actually call Fatima and say, Fatima, I need my follow-up vaccine dose. At the end of the year, I realized that vaccinating the Bronx was probably not financially viable. And starting January, we decided to offer free vaccine to everybody, but ask them if they had insurance. If they did, could we use their insurance? And we reviewed the data for the program effectiveness. And to facilitate people coming in to let us know what they did and getting informed consent, we said, you come in, we'll give you a free blood pressure cuff and a travel stipend. So we looked at the first 500 who were screened, who were antibody negative, and we asked a couple questions. The first was, did you get the first vaccine and did you complete the series? And if you did, where was it? PCP, Department of Health, or the program? Timing of vaccination in relationship to vaccine availability, whether they refused vaccination or they were lost to follow-up and died, which is very important. So a third of the patients were antibody negative, and we divided the cohorts into three. So A were those who were screened before we had the vaccine. B was 2021 when they were screened and we had vaccine to offer immediately. And then C were those in 2022 who we had the vaccine, but we also offered an incentive to come in for vaccination. So this slide compares cohort A and B. So in cohort A, so those are those who were detected, screened before it was available. A third of them went to their PCP for vaccination. 4% went to Department of Health. A quarter of them called when we offered the vaccine and immediately came back. A couple percent, 7% required the incentive. 13% refused. 12% were lost at follow-up. 2% died. So overall, 72% came in got the first dose, and 88% were compliant with the series. Great numbers. In cohort B, it was even better. 88% got the first dose, 90% were compliant. Now, the important question is, why did they get the vaccine in the program? And we broke them down to three categories. One, they were not integrated in the US healthcare system. They did not have insurance. So they had no other option. The second was the PCP did not recommend it. And the third was trust. So they had insurance, they had a PCP, but they wanted us to do it. This trust issue is extremely important. There were actually Montefiore employees who for years knew they could have gone to employee health to get vaccinated. They refused. When they heard that we had this program, they came to us so we could screen them and we could vaccinate them. So what's the takeaway issues? Well, insurance coverage and healthcare integration are not major factors in limiting vaccination in the Bronx, West African community. Vaccination in a culturally sensitive screening program is highly effective to trust, and timing is very important. You need to approach them at the time of screening, not 1 or 2 years later. So I would like to end with another program that we conducted, and this question whether can the HB screening educational model be used to address other healthcare needs. specifically hypertension, and promote HBV screening. And I term this meeting the community halfway. We chose hypertension for a couple of reasons. One, it's very common. It's a significant cause of cardiovascular morbidity and mortality. It's readily acknowledged. And we knew that there'd be a very positive response based on our experience in the hepatitis B vaccination program. So we developed two presentations. One was a 30-minute educational program using the Hep B as a presentation as a template. And then there was a 5-minute presentation. So Fatima would be at a meeting and they would say, Fatima, can you get up and talk about hypertension? So she would get up and just give a 5-minute off-the-cuff presentation. And at both sessions, we would she would take names and numbers for those interested in coming in for screening. So at the time of the screening, she would do a blood pressure check. We would give everybody a free blood pressure cuff and instruction for its use. The blood pressure cuff was spectacular. A lot of people came in without hypertension. They just wanted the blood pressure cuff. We also then performed Hep B screening. And very importantly, we obtained referrals of family members and friends. So there were 7 30-minute presentations and 5 5-minute presentations. 455 attended a 30-minute presentation. About half requested a clinic screening visit, and 80 attending a 5-minute presentation requested a screening visit. Of these, 252 were seen in a clinic visit. Interesting, only a third of those who went to the 30-minute presentation came in for screening. I speculate that the possible low number was because we actually did blood pressure screening at the time of the event. But there were additional patients who did not register, who would give Fatima a call saying, Fatima, I was at the meeting, I didn't register, I'm downstairs, can I come up and get screened? 2/3 of those attending a 5-minute presentation showed up, and then an additional 4 who were at the presentations but did not give their names called to come in for screening. And very importantly, for every 3 patients we screened, they gave us 2 additional names who came in for screening. So of the 252, 250 agreed for Hep B testing, 2 said no because they had just been tested, and of these, 7.5% were surface antigen positive. So this highlights another very important point, that it's important to address the concerns of the community. And then I would like to end with that the community has to be recognized. The 2 major individuals who ran the program, Fatima and Dr. Mazaboa, basically became rock stars in the community. They got multiple awards from the community, from the mayor, from the Bronx City Council. And I think it's very important that the community know it's not about the government, it's not about the hospital, the physicians, it's about the community helping itself. And then I would like to end with, it's extremely cost effective. We have basically volunteers who were residents, medical students. The only person who had a salary was Fatima. She would get calls all day long for people interested in coming in for screening. And here I show that we looked at hypertension, but we also looked at added hemoglobin A1C for diabetes screening. We did a little in-service on malaria prophylaxis, and we were able to transition to care. Thank you.
Thank you so much. Thank you very much. Many lessons to be learned from your presentation. I know some of this is, you've already published some of this, as you noted in some of your slides. So we want to make note of that, those resources. And also just your, calling out the importance of local champions at the community level that make this kind of work possible. So thank you again. And again, please share comments and questions. I think you already have a few there in the comments in the chat section. Let's move on now in the interest of time. For the next presentation. To Rachel Meltson, who's the Outreach Clinical Director for the SWOPE Health Clinic in Kansas City, Missouri. We're talking about extending hepatitis C testing and care to persons experiencing homelessness. Rachel.
Great, thank you so much. Hello, everyone. My name again, it's Rachel Melson. I'm the Outreach Clinic Director at Swope Health. Swope Health is the largest FQHC in the Kansas City area, and we've been providing care to an underserved community for over 50 years. Today, I want to share with you how we provide testing and treatment for hepatitis C for people experiencing homelessness. We do that through a flexible, community-based model that integrates screening, treatment, and partnership so we can best meet patients where they are. So I start just about every presentation I give on hepatitis C and our program at Swope Health with this slide. I love it because we don't get to use the word cure much in medicine, but as we all know, we have a cure for hepatitis C. The problem is so many people don't know their status and can't access treatment. Each year, over 15,000 people die from hepatitis C-related illnesses, and unfortunately, people experiencing homelessness are disproportionately affected. It's been hard to estimate how much Hep C truly impacts the unhoused community in the United States. Studies have varied and shown it's anywhere from as low as 9% to as high as 60%. There's a really interesting study that was done in Los Angeles on Skid Row, where they found that around 26.7% of adults experiencing homelessness were impacted by hepatitis C. And at 26.7%, that's more than 10 times that kind of 2% overall rate that we see in the general population. More surprisingly, less than 3% of those persons had actually ever had access to treatment. Closing this gap is essential for any local, state, national, or even global elimination efforts. So why are people experiencing homelessness so disproportionately impacted? Well, it's because hepatitis C, as we know, doesn't exist in isolation. It's a part of a syndemic where Hep C overlaps with housing instability, substance use, mental health conditions, and even risk for other diseases like HIV. And then all of that is layered with, other social determinants, other health conditions that each of these individuals may face when accessing healthcare. So these challenges reinforce each other, and our care models have to address all of them together to really be effective. We have to focus on integrated and flexible and community-based care models that address multiple needs often at once. So again, our patients face these barriers and layers, right? So the most significant are those competing priorities for just survival. We have structural barriers that include systems that have like siloed health and housing and harm reduction services. We have structural barriers that created a deep-rooted mistrust from the trauma that happens when accessing a healthcare system. And then that's further layered with stigma. Finally, we have tons of policy barriers that I could spend another hour talking to all of you about. But we have sobriety requirements and restrictive provider requirements, and these keep patients from accessing a streamlined opportunity for care. So at Swope Health, in our outreach clinic, we provide holistic medical care at shelters, transitional living facilities, halfway houses, domestic violence centers, and directly on the streets through our mobile medical unit, which you can see on the picture here. In that unit, we offer for every patient an opt-out model of hepatitis C and HIV testing, and we integrate our hepatitis C treatment into our overall primary care services. All of the providers in my clinic are not only equipped as primary care providers, we all provide hepatitis C testing and treatment services. We started our hepatitis C treatment program in 2019, and I am so proud to share that since that time, we've helped almost 700 patients access treatment for hepatitis C. So our success really depends on our community partnerships. Partnering with the local shelters and street medicine teams and resource hubs has helped us tremendously. And consistency has been key for us, not only just with our partners, but with our patients, showing up in the community over and over again when we say we're going to be there. We also emphasize opt-out testing to try and remove the stigma from knowing your status of hepatitis C and HIV. We integrate our care with chronic disease management and harm reduction. You want to make the most out of every visit when patients are accessing their healthcare. And sometimes that means creating a more holistic and integrated approach. Flexibility is one of the most important considerations when providing care in this population. Imagine the city bus is your only mode of transportation, and now it's running late, and now you're 2 hours late for an appointment. Now, what are you going to do? Being open to things such as late arrivals, allowing for walk-ins, even converting visits to telemedicine visits are all ways that you can help meet your patients where they are. Something else that has really helped us is simplifying the process for patients in accessing medications. Most barriers in healthcare really compound on each other. You hit a roadblock after roadblock and you start getting discouraged. We want to give our patients the illusion of ease. Even if we know the prior authorization process isn't something that's going to be easy for us, we want to make it seem like it is for our patients. We want to let them know that we've got this and all they have to do is show up and take their medication. The goal here is truly like a low barrier access to care. So I wanted to highlight how we provide this care with just a few examples that I've had in my clinic setting. So here we have a 22-year-old man who regularly sleeps outside, and he approached our mobile medical unit at one of our regular Thursday morning locations. And so he presented because he wanted help with his daily fentanyl use. In my discussion with him, he was very comfortable with the resources available and knowledgeable of the city bus system, but he absolutely did not want to walk in the walls of our brick and mortar clinic site. And so we, in that moment, we provided point of care testing for him. He tested positive for hepatitis C. At that time, he was negative for HIV. So how did we meet his needs? In that moment, we decided to do a lab draw on our MMU. That's what we call our mobile medical unit. We discussed Suboxone services and MAT and what that would look like with his current fentanyl use. And, we discussed opportunities for HIV prevention through PrEP. We encouraged him to continue to come see us every week on our mobile medical unit, again, at that spot that we routinely go to on Thursday mornings. And, because we chose this kind of flexibility, this low barrier approach, this patient now walks around with naloxone in his pocket. He has continued to follow up with us. He actually comes to see us still, even after he's completed treatment. Every Thursday morning, he comes to say hi to us at this location. He's no longer using fentanyl. And he's still, to this day, this was a couple years ago, he's still on HIV PrEP. We've engaged him into a recovery program, and he's doing really well. This was all done without walking into the doors of our clinic building. We, again, opted to create this kind of coordinated and patient-centered kind of tailored approach to his care because that's what he needed in that moment. So just another quick example of a patient that we saw over the last couple of years, a 58-year-old man. He was engaging in treatment, came onto our mobile medical unit while we were on site at the shelter providing medical services. This was somebody who had attempted to try and get treatment in the past, but had been lost to follow-up after getting his first box of medication. He never took more than a week. When he came onto the mobile medical unit, he was ready. He was engaged. He was really excited about being in the shelter. He was going to be starting a program with them. So we opted to go ahead and start him on some medication that day. And we scheduled him to come into the clinic for a 4-week follow-up. And of course, unfortunately, he did not come to that scheduled appointment. So what did we do? We have, a really great partnership with the shelter and a MOU for our care coordination. And so we were able to reach back out to him through the shelter because we had seen him there. We knew that he was staying there. Our Hep C nurse partnered with the shelter's medical coordinator and arranged a walk-in visit for the next day. And then we just followed through with him and ensured he completed the treatment and he achieved a cure. Now that success was possible because of that strong community collaboration that we had. So what has worked for us overall? You know, it's really creating processes that encourage meeting people where they are, both literally and figuratively. You really have to get to know your community and the resources they have available. You know, where do your patients go to eat, to sleep, to shower, to get meals? You want to create partnerships with those locations and be visible in the community. This will not only help you build trust and rapport with patients in the community over time, it will show consistency so that you can lean on your community partners when you need to help really coordinate that patient care. And we also learned that we need to be flexible, again, creating opportunities for low barrier healthcare access. Now, I will be the first one to tell you I'm very type A. I love my routine. I love my schedules. And working with this population of patients has really challenged me as a person because you really have to be flexible. You have to, know how to adapt in the moment because that's what your patient population needs. Community-based models can really close gaps in hepatitis C care for persons experiencing homelessness. And again, the core ingredients of this are creating those partnerships, flexibility, and trust. A couple years ago with the National Healthcare for the Homeless Council and NVHR, we created this hepatitis C provider pocket guide. It was created to help support clinicians in working in this population with screening and prevention and treatment. It does, as a disclaimer, need a little bit of updating for some of the newer guidelines, simplified guidelines from the AASLD and ISDA, but I can provide a link to this in the chat if any of you are interested. Again, I want to thank everybody for the opportunity to share our work on this topic. I tried to get through it as fast as possible, but I love talking about not only providing this kind of care in populations of persons who are experiencing homelessness, but talking about hepatitis C testing and treatment. Feel free to reach out to me if you have any questions.
Thank you so much, Rachel. That is fantastic. It's a remarkable 700 people treated for hepatitis C. What a great accomplishment.
Thank you.
Population is really, challenging, as you made evident. That's just really, really a big achievement. So I just want to extend my thank you and congratulations to you for that. And you sort of began to reveal how you made that happen. So thank you. Please submit questions in the chat or in the Q&A, please, and let's move on just to make sure everybody has their time to speak. We're going to move to South Carolina now to hear from Wesley Wampler and Miranda Gormley to talk about outreach in South Carolina, particularly in rural areas of South Carolina, and really bringing different parts of government agencies together to extend access to care and treatment for hepatitis C. Wes, Miranda.
Good morning, everybody. I am Miranda Gormley. I'm an epidemiologist at Prisma Health in South Carolina, and with me today is community paramedic Wes Wampler, who runs our CP-HCV iLink program. And today we're going to talk to you about pathways to the cure, mobile integrated healthcare transforming hepatitis C treatment through community care. So this project is possible through the front lines of communities in the United States or the FOCUS program, who provide the funding for our opt-out program that screens for hepatitis C virus and HIV in our emergency departments. I know a lot of you probably know about opt-out screening programs, but I'm just going to summarize here. If you step foot into my ED, we hand you a piece of paper that says that you will be screened for hepatitis C virus or HIV unless you elect to opt out. If you don't opt out, then we test you and we send your results to your MyChart app. app. If you are positive, one of our care coordinators contacts you and then tries to link you to care. And we find that we have a pretty good success rate with linking people to care. About 2 out of 3 of our patients are linked to an outpatient appointment. However, there is that 1/3 that even when they are linked to an appointment, they don't come or we can't get a hold of them. And so we really wanted to focus in on those hard to reach individuals. And so we started calling some of these individuals and just asking, why aren't you coming to treatment? And we found a couple common barriers. The first and foremost was transportation. Many of our individuals are very rural. And so a lot of them arrive to the emergency department by ambulance. They don't have a personal vehicle. Additionally, Uber and Lyft do not exist for these individuals. But even if we were able to get Uber and Lyft for most of them, some of them have a medical condition that impairs them from being able to take Uber and Lyft to receive an office-based treatment. Additionally, no health insurance is a huge barrier for many people because they feel that if they don't have health insurance, that they just can't get treatment because it's too expensive. Further, no cell phone or poor internet access keeps us from being able to do effective telehealth communication with these individuals and their homes, eliminating the possibility of doing a telehealth intervention. And finally, there are some other financial barriers. Many of these individuals are newly employed or employed at places that are not okay with them taking time off to travel to and from an office-based appointment. And so these are the main barriers that we wanted to address with the CPHCV iLink program. This is a multidisciplinary program that brings together a community paramedic or a paramedic who does public health functions in the community with an infectious disease provider. They work together to do a physical examination and then a telemedicine visit with the patient in order to get them started on HCV treatment within their home. So I'm going to briefly go over our eligibility criteria. Patients have 3 ways that they can be entered into this program. First and foremost, when my care coordinator contacts somebody, if those individuals say that they have a barrier, any of the aforementioned barriers to attending those appointments, they are put into the CPHCV iLink program. 2, if somebody is scheduled for one of our office-based appointments and they do not show up, we have the care coordinator follow up with them to see why and enroll them in the CP program if necessary. And finally, we have a couple people that come to the office-based appointments and then they just stop showing up, right? So we have the care coordinator contact them. She does a reassessment of their social determinants of health and she determines whether or not any of those barriers are present and then links them into our program. So now that I've told you about the eligibility criteria and a little bit of the background, I am going to turn you over to the community paramedic that runs our program, Paramedic Wampler.
Hi, everybody. So after these patients are identified, our care coordinators, they schedule a telehealth appointment and with the community paramedic. We arrive on scene, we do a focused exam, we do a 12 lead if necessary, obviously vital signs. I'll touch on this in a little bit later, but we can do the fiber scan on scene. We obtain labs that are necessary, and then we coordinate the telehealth encounter with Dr. Rolfe, our primary infectious disease doc, or one of the nurse practitioners with our addiction medicine center. At the time that we visit with them, we get the paperwork submitted. If they're uninsured or underinsured, we do financial assistance through the hospital to get that worked out. We try to identify other social determinants of health that are limiting, including we'll help them apply for Medicaid if necessary. We will help them get their medications that they probably haven't been taking or not, they can't get acquired. We'll get food for them through different programs, do whatever is necessary for that. So at the end of the encounter, we'll get the labs that are ordered by Dr. Rolfe. We'll take them to the lab. And then if the patient has stable housing and the patient has somebody there that can sign for the medications, we'll get it delivered directly to their home. If they're not able to do that, if they are homeless, if they don't trust their neighbors, whatever it is, we can get the medicine shipped to the clinic, and then I will go pick up the medication and get it to them. At 4, 12, and 24 weeks, we'll go back, do follow-up labs. We'll check in with them, see how they're doing with their treatment, and address any other issues that have come up along the way. So here's kind of a timeline of how it works out. So patient is tested for HCV. Hopefully we get the results within a couple of days. The iLink coordinators hopefully will contact them within hopefully 10 days and set up an an appointment for the telehealth encounter. We will arrive there. We will complete financial assistance. We'll get that. Usually it takes about 2 weeks, maybe a little bit less, to get the medication approved and get it out to them. At 4 weeks, we'll redraw labs to make sure the treatment's working for them. 12 weeks, we don't often get 12 weeks anymore. We used to at the beginning, but certainly at 24 weeks, we'll get the SVR labs. And then within 6.5 months of initiating or identifying the patient, they'll be cured. So this is kind of our numbers so far. Our payer mix, 1/5 of our patients are self-pay, and these patients, like I mentioned, that we'll do the paperwork necessary. We haven't had a single patient that we've had that has not gotten their medication. We will Medicaid is 40%, Medicare 20%, and then private other insurance is about 18%. So we've had 108 patients linked to the CP program. 3 of those patients, we had the appointment set up. I went to their door and they didn't answer, and then we weren't able to get in touch with them, so they were lost to contact. Of the 105 patients, 4 patients unfortunately passed away during treatment. 4 patients were discharged for loss of contact after the initial encounter for various reasons. Maybe they moved out of state or they just stopped answering the phone. There are 29 patients currently in treatment, or 27%, and then 68 patients we've cured, or 65%. This is the cost estimate for a community paramedic, including the hourly rate, including mileage, anticipated vehicle costs, the cost of supplies. This obviously does not cover the initial startup, onboarding, the initial cost of the vehicle, the equipment. That's a pretty hefty price. But afterwards, each patient, we've estimated about $278 per patient for the community paramedic to respond out and take care of that. This is our addiction medicine mobile clinic that we have that goes to 2 communities in the upstate. They are staffed with a nurse practitioner, a social worker, a peer support engagement provider, and then research providers. A lot of the patients that are here, they'll start out in the mobile clinic if they can make it to the mobile clinic, and then something comes up in their life that they can't continue coming to the mobile clinic, so then I will go out and see them. Or if there's resources at the mobile clinic that I can't help them out with, there's some stuff that the social worker or especially peer support can't help them out with, I will facilitate getting them to the mobile clinic to get that treatment or intervention. And then there's some other research opportunities that are available that we have personnel there for. This is one of the devices that we have just started to use. It's the FibroScan. This device is we're in its infancy. It's a non-invasive ultrasound procedure used to assess the health of the liver as far as stiffness and fat content. Liver biopsy obviously is the gold standard, but that's a lot of people can't get those liver biopsies, and there's a lot of side effects associated with them. The sensitivity and specificity of especially in the higher fibrosis stages are very high. But we're using this program. We've scanned 10 patients for the HCV iLink program, and also 2 patients in the mobile unit. We're still trying to finish up training, and we'll incorporate that more in the near future. This next device is the Cepheid point of care testing. We had just acquired this device, which has been a huge help. For those not familiar, this device will test the patient for the PCR by testing just a capillary blood, a very small amount of blood. It usually takes about 45 minutes for the patient for a positive to come up. It takes about an hour for a negative, and the quantitative range is as low as 10 international units per milliliter. The sensitivity and specificity of this test are about as high as you can get. And the advantage to this is that our regular lab, the HepCRNA quant, it requires a regular lab draw. We have to get it to a lab that's not Prisma. They run it for us. It takes 3 days to get back. It's a very costly lab. This device, we can get results within an hour. and which can kind of generate our treatment options and evaluate our treatment. And it's a very, very low cost. So we're still in its infancy. We just got this device this year and started using it. It's a great device that I think we're going to expand more the more we find ways to do that in the jail setting or what have you. But so why does this matter? This gentleman is William Westfield. He was one of our early patients back in 2021. I met him after he was found to have HCV through an unrelated ED visit. He had huge distrust in the medical community. He was very hesitant to even let me in the door. I after some talking through the door, he let me in. So his blood pressure initially was 200 over 100. We had the telehealth encounter. Labs were difficult. The Cepheid would have been nice in that case, but with that initial encounter, we were able to get him blood pressure meds. I went out and picked that up. We were able to set him up with transportation to see the addiction medicine specialist to get on Suboxone. I went back, I think, 3 or 4 times that week, 3 or 4 times the following week, and we had his blood pressure kind of under control. He had several other things that we had to help him out with, or I got the opportunity to help him out with that were challenges for him. We got him cured of his Hep C, and I actually had the opportunity to go to California with him. It was his first and only flight out to California to discuss his case at a national conference. He has a truly heartbreaking story of what he's gone through. But one of the things that he said, it gave him more time to spend with his granddaughter. He said when he got home from work that he was tired. He didn't have enough energy to be with her. After we initiated treatment, he got cured. He spent every day with her. Unfortunately, I spoke at his funeral back in April of this past year. He passed away from a cardiac event, which was heartbreaking, but a wonderful guy. Which programs like this were, and like what you all are doing, were in place 15 years ago, because unfortunately, he had several years after he got treated, but he should have had more. I appreciate all you do and can attest that there were many, many more individuals like Mr. Westfield that are given an opportunity for a more healthy and enjoyable life because of individuals like all of you. So I appreciate the opportunity, and I think you're gonna send a link for.
I have a link. Mr. Westfield did an excellent presentation for us for Fox News to talk about our program and how it helped. This is a really good example to circle back to what Rachel said about how you have to address multiple layers at once. And paramedic Wampler and the other community paramedics that work with him are able to address HCV, and they're also able to connect them to treatment for primary care issues such as hypertension and opioid use disorder. So that is the wonderful benefit, and very cost effective. And that's the wonderful benefit of having this program using community paramedics. So thank you very much. We'll take your questions in the chat.
Thank you so much. I was tremendously energized when I heard about this at the Global Hepatitis Summit in Los Angeles back in March. I had never been familiar with a paramedic outreach such as the type that you have put in place in South Carolina. I think it was really very innovative and seems to be very well accepted. And just thank you so much for this new way of extending care for hepatitis C to this population. So let's turn over our final remarks from Dylan Moore from Arizona. Let's get his first slide up there, please, Lindsay. And who's the director of the VIN Centers at Arizona Liver Health. Dylan, thank you so much for joining us.
You got it. Thank you, John. Definitely amazing to hear all of these wonderful and innovative programs across the United States. My name is Dylan Moore. I'm the director for Viral Elimination Centers, which is a mobile outreach program under Arizona Liver Health. And want to take this moment up front to recognize the team that we have from our outreach coordinators, our case managers, our prior authorization specialists, our providers, because they are truly the heart and soul of this program and took this concept and have made it a reality. So big shout out to anyone that may be on here, but this team is outstanding. and has led us to where we are. All right, so a little bit of background of who we are, what we're doing. So Arizona Liver Health was created in 2017. It was a group of hepatology providers that had worked in transplant hepatology, have decades of work with hepatitis C across the southwestern region, and started this outpatient hepatology program. And so for a landscape 2021, Arizona Liver Health, or not Arizona Liver Health, Arizona received a scorecard of F for the testing and treatment that was taking place across the state for hepatitis C. And that was obviously something that we needed to change. And so ADHS actually reached out to Arizona Liver Health leadership and worked and established an MOU that ultimately provided ALH with 340B status. And with this, so that is our funding source, but very different than a lot of other states. Arizona does not include Medicaid patients in the 340B savings. So limited to Medicare and commercial insurance, which is only about 20% of our patient population. So 80% being Medicaid, as you would expect from the higher need and demand for hepatitis C treatment, is where we put our emphasis, and where we really want to focus this program is more in those communities that are unserved, underserved in identification of and elimination of hepatitis C. So for Arizona, somewhere around 90,000 estimated cases of individuals living with hepatitis C. And back around that time in 2021, Arizona Liver Health was the largest treater of hepatitis C in Arizona, but was only treating about 150 people annually in clinic, with another somewhere around 50 individuals in rural areas from consultation. Dr. Manch and Ann Moore actually were some of the individuals and early users of the ECHO program in the Southwest to try to make sure that we were accessing those rural communities, helping providers really work in those areas to treat hepatitis C through that consultation. But with 150 annually, it was obvious that we needed to do something very, very different. And so leadership got together, ultimately deciding and coming up with this program for viral elimination with a primary goal of eliminating viral hepatitis in Arizona. And really a big focus on making this community-based. And there's a theme here with these last few presentations, as you can see, really bringing a model to the community, bringing it where people are, ensuring that that access is there for any individual that is ready to engage with us. And so like to bring stories into this. This is Santiago. This is someone that I met at the very beginning of this program. So Venn Centers, we started at the end of 2023, and his story is not unique to him. This is something that we see across the United States pretty consistently and even globally, that he had tried to seek treatment. He had known that he was living with hepatitis C for over a decade, on numerous occasions tried to engage in treatment, but was told that his fibrosis score wasn't high enough, his RNA levels weren't high enough, that it was going to be too expensive. And ultimately, he lost faith that he was ever going to be able to be treated and gave up on actually engaging with providers at that time. So Arizona Liver Health, these are our clinic locations. This is where we're operating for our brick and mortar facilities across the state. So Phoenix, as you would expect, has in the valley around 7 million individuals living in that area. So we have a big emphasis on our clinics there. Up in Flagstaff and then down in Tucson with another somewhere around 1.5 million. And knowing that we were not seeing the elevation that we wanted to see in terms of our engagement, whether it was out in the communities trying to get people to come into the clinic through referral sources or just advertising and education of hepatitis C, we knew that we needed to become much more available. And so these mobile services, and we put a big emphasis on telehealth with the fact that we knew this would maximize our number of outreach coordinators out in the community. And these are the areas that we're testing across the state on a very regular basis. So this is out, whether it's, and we really make sure, so street medicine is where our bread and butter is. So we do have mobile units. We do work with a lot of other partners from, as you'll see, recovery centers, reentry programs, homeless services, harm reduction programs, SSP sites. But we like to get out and make sure we're on foot. When we say bringing care to the individual, we mean that. And so we have locations, we're out in the community, but the problem is that we're still seeing, and this was Arizona Liver Health's old model, so many visit requirements for patients, and this is still happening. Even with the simplified treatment models for hepatitis C, we're still requiring all of these touch points for patients. And every single one of these visit requirements is one more opportunity for someone to fall out of care. So the goal on our end is we wanted to simplify this and make it as easy as possible, knowing that we have very efficacious medications that are very safe with limited side effects, and having the historical treatment and decades of experience with hepatitis C treatment internally, felt very comfortable and confident moving forward with a one visit program. So where whether it's screening or someone knows that they're living with hepatitis C, that we're providing phlebotomy for confirmation in real time. Now also elevated, as mentioned by the other team, with the point of care RNA testing possibility, but then a provider visit, as I mentioned, for telehealth, and that we're getting all the necessary paperwork. And similar to Rachel's program, where she relayed of finding all of the different potential for follow-up. So when you're working with individuals that are unsheltered, of knowing where are you using the bathroom, where are you sourcing your food, where are you going to be sleeping this day of the week, so that when we ultimately bring medications or get medications approved to get back to them, we have all of the different locations that they may be located, because most of the people we're working with don't have phones. But this part, as you all know, prior authorization is still a mess. So Arizona has technically on paper, treatment naive individuals don't require a prior authorization. But that water is muddied when we see things. We have a lot of fraudulent ACA enrollment and different things that are taking place, to where we had eliminated some of the barriers for treatment approval and lack of PA need. We're seeing this go the other direction. So lots of work to still be done, but on our end, whatever we can do to limit the needs of the patients and take care of this on our end, we're trying to make happen. Case management is something that I could go into for a long period of time with how we actually make this successful with various populations, but it's 10 minutes. So these are some of the locations that we have. This is just examples of where we're at when we're talking about this. The next slide. And as mentioned, collaboration with other organizations, partnerships, relationships are essential, so that we're not only ensuring the success of their hepatitis C test or identification and treatment, but the success in other areas of their life, whether it is substance use disorder or simply housing, transportation, food insecurity, any of those things that we're working together. But as you can see here, some of this is the encampment. We give large presentations at reentry centers, recovery centers. We've got the Cephia that you'll see coming here out of the back of a trunk. I told Cephia that we would put this thing to use, and we certainly have. So we're throwing it anywhere that we can, getting it out into the field, so that we have that real time, not only for individuals that are able to go to the clinic, but truly in the community as well. So these are the numbers just for 2025, and this is our screening. So we do use the OraQuick point of care antibody screening, as mentioned, now elevated with the point of care RNA ability. But the blue highlights individuals that we have found that were brand new cases, previously unknown exposure. And as would be expected and holds true to the numbers, about 40% of people when we're out screening are aware of their hepatitis C status. So recovery centers, harm reduction, guerrilla testing is how we call it, really just out with backpacks. So at gas stations, at bus stops, walking streets, everything that we need to do a visit just in our bags. So true street medicine, but bringing this out into the communities. And we have a very passionate group of outreach coordinators that make this happen on a consistent basis. We would not be successful without them, that is for certain. We also just recently, we were fortunate that the Cephia Gene Experts, our program actually had, from a clinical trial perspective back in COVID, that had just been gathering dust. So the fact that we received FDA approval for the HCV point of care testing this year was amazing. And we just started in April. So these are test up volumes from the beginning of April to about last week. So just over 120 total tests performed. And big takeaways up front that I can relay on a high level. Truly the real-time awareness of whether or not somebody is going to need treatment, usually about 41 to 45 minutes for those positive results with HCV RNA detected, and somewhere running that 60 minutes for non-detected patients. Something that was pretty alarming to me, or that we saw really quickly, is the number of individuals that were their awareness was that they were living with active hepatitis C and that they were in need of treatment, that ultimately had actually seroconverted and that they were not in need of treatment. And so being able to educate real time was very significant on our end for those, and be able to provide that the education about re-exposure, everything that entails, but then truly to be able to have them walk away knowing that they're in a place where they do not need treatment. As stated, so for Medicaid patients, we're still not seeing approval for this for commercial or Medicare, but Medicaid of not having the prior authorization requirement for treatment naive individuals, we saw a reduction in time of about 48 to 72 hours in getting meds in hand because we're not needing to utilize, we can submit the prescription without having to wait for that confirmatory phlebotomy. So that is the most significant thing that we've seen up front, and hopefully we'll have some more data to come as we continue using this. This is the biggest comparison, or this is kind of the ultimate display of what the significance is of this program. So as you can see, the bottom light blue line is our ALH clinics. So we've stayed pretty consistent in the volumes that we've been treating through clinic through referral, but you can see that significant gap and that we've been able to continue on this trajectory as we're kind of getting our feet under us. And this program is less than 2 years from its inception, and continuing to see an increase in the number of patients. And these are the number of patients that we were writing DAAs for. Ultimately, our loss to follow-up is just under 20%. And with that, for the population we're treating, I will take. Obviously, we want to get that down as close to zero as possible. But these are individuals initiated, engaged, and prescriptions written for treatment that ultimately and likely would not have sought care otherwise through our standard clinic methods. So goes to show that it is not a one-size-fits-all. We've seen 4 or 5 different programs that have been illustrated today, and every single one of them has their success, has their place in this treatment, and it's going to be the layering of many options for individuals to make sure that we have an option that works for them. Bringing it full circle, so Santiago, and again, this was at the very beginning, so back in 2023, from meeting him, from the first words that I spoke to him, within about 30 minutes, we had that all completed, from his paperwork, his lab draw, provider visit. Next time I saw him was 3 days later with meds in hand. So made this successful. Now with the Cepheid point of care, we're hoping to reduce that even further with a specialty pharmacy requirement. That's our next step, is to try to partner with a specialty pharmacy so that we can do that same day. I know a lot of you on here probably know Tony Martinez and La Bodega out of New York that have that opportunity to do same day medication handoff. That is the goal that we would like to do in an outreach capacity to be able to move that from that step of brick and mortar to the same day movement in person in the community. Again, thank you. This has been an honor and a privilege to be able to speak here. And elimination truly is not theoretical. As you've seen from every single one of these groups, it really is about making sure if we have somebody ready to engage in treatment, we are making that as seamless and easily accessible as possible. Thank you.
That's great. I fully agree, Dylan. All of these programs demonstrate that elimination is possible and is being achieved for these marginalized populations, thanks to all of the good work represented here today. Thank you so much. Yeah, Dylan, I want to give you an opportunity to give you for you to plug your conference coming up in early October. You want to, and we're going to have a satellite learning session along with that. So why don't you let everybody know about that conference, please?
Yeah, appreciate that, John. So October 4th, conference is called Doing It in the Desert, focused on hepatitis C elimination and STI prevention and elimination as well. INSU is going to be doing on October 3rd. We'll have a day that's going to, I believe it is 8 to 5, but is going to be, I'll put a link in the chat here if I have a minute. But that's going to be on Friday. Saturday will be the Doing in the Desert conference. Definitely some overlap, some beautiful conversations, wonderful individuals from not only the United States, but abroad that are working on programs towards elimination. On Sunday, we're actually going to be offering an opportunity to take this into the streets and have some real-time learning from different groups. And we're going to be doing outreach in downtown Phoenix with Ben. And on the registration site, there's an opportunity to put in there if your team or anyone is interested in volunteering to get out and see what we do in our practice in Arizona. And that there can be some multi-directional learning there.
Thank you. Yeah, we really appreciate co-convening those sessions with INSU. I look forward to participating in the Doing It in the Desert conference, as well as the learning session that will precede it. So please join us if you're able to. We have a few minutes for some questions, so please put them. I think it's best to put them. I think there's one question in the Q&A already for Dr. Sigal, is there any capacity to use this community-based model for other causes of liver disease?
Yeah, I think the model can be used for basically any medical condition.
Sure.
I've adapted it to actually translated into Russian for the Central Asian community in Queens, where there's a very high prevalence of hepatitis B from people from Uzbekistan. Again, we did it for hypertension. It can easily be done for fatty liver disease, basically any medical condition.
Okay, thank you. One question I had, I think maybe I just can go around the screen, is sustainability. These programs are, no doubt effective, very innovative. Seem like you've already marshaled really, a great deal of support from multiple key stakeholders as well as in the communities. And maybe, Rachel, with your longstanding success, maybe yours is the one that's sustained already on a day-to-day basis. But I just wanted to call on everybody about, what's the prospects for sustainability of these kind of programs. Rachel, please.
Yeah, absolutely. So I think one of the challenges currently is, Medicaid is one of our biggest payers at our FQHCs. And so really just understanding what that's going to look like in the trajectory for the future. That's one of the reasons we've been able to sustain ourselves for so long. I'm fortunate that in the state of Missouri, we have what's called Project HepCure, which has removed all of the barriers to treatment for Missouri's Medicaid payers. So there's no prescriber restrictions. I don't have to get a prior authorization to get medication for Missouri Medicaid. We also have expanded Medicaid in the state of Missouri. And so that has really helped us with creating the foundation for sustainability in our program. We also, because we're an FQHC, we can leverage 340B as well. We are currently partnering for some future projects right now, getting some state grants for sustainability, not only for our program, but looking towards creating, we're doing a rural health telehealth program at this time, and providing from Kansas City hepatitis C testing and treatment across the state. These are for people who are getting out of Department of Corrections and for people who are in rural Missouri without any other access. And we're going to be providing those telehealth services and having some grant funding to cover that. But, the sustainability for hepatitis C treatment, unfortunately, is the fact that it is still so prevalent, and we are going to continue to need these treatment, just sustained treatment models going, further into the future to be able to successfully eliminate hepatitis C. And then hopefully I won't need sustainability in my program because we're going to right?
But that is the ultimate goal. Yes, absolutely. Please take the evaluation poll that's popped up on your screen. But I want to turn to Wes and Miranda to get their point of view about sustainability of this very innovative and effective program.
So when we talk about sustainability, I want to be clear that we're talking about the sustainability of the community paramedic going out and conducting these activities. And we had initially a $20,000 seat grant from our community to start this program. After we finished it and we cured the first 50 people, as you can see, it's very cost effective for Wes to go out. However, Wes cannot get reimbursed by Medicaid, Medicare, private insurance, et cetera. There is no reimbursement mechanism for a community paramedic. However, Dr. Roth does get reimbursed for a telehealth visit. So the hospital decided that they would pay for Wes's time to do this. So we currently are using a sustainable program. Now, it's sustainable because our hospital provides support, but they are providing support because while we have not officially done the cost effectiveness study, we know that by treating these individuals and their HCV, we are keeping them from utilizing emergency medical services and the emergency department, as well as hospital admissions in the future.
Thank you. Real quickly, you mentioned a self-pay option there on one of your slides, and I'm not quite sure what the patient is paying for. Is that the clinic visit or what, please?
So self-pay is the way that Epic refers to individuals that do not have insurance. So self-pay means that they are uninsured. The way that those individuals pay is that we often get them on a program that I think it's who pays for the medication. Is it the company?
The pharmaceutical company.
The pharmaceutical company will put them on a sponsorship to
program.
Do it. Yes, and then we put them on a Prisma Health program to pay for their visits.
And the labs.
And the labs.
Thank you. I thought that was the case. There was probably a patient assistance program involved. Thank you very much. Dylan, you look like you already have an extensive network of testing and treatment. So maybe this is already a sustained program, but please comment on that. Thank you.
Yeah, I mean that was the goal out the gate, is to ensure that we were growing in a fashion that would be sustainable. At the same time, as we've seen, the healthcare landscape in the United States is tumultuous to say the least. And I mean, the exciting factor here is the legislation that was just proposed with Senator Cassidy and Van Hollen, to see what comes of that for medication availability. But a lot of it is going to, obviously, for all of these programs, come down to funding. Um, and with that, we do believe, from an Arizona liver health perspective, that we've set ourselves up for success longer term. But a lot of that does come at the determination of the legislation that's to come.
Thank you. And Sam, please.
I mean, I can address that based on experience. So I left Montefiore 2 years ago, and my coordinator, Fatima, has actually continued doing the outreach screening programs. She hasn't, I mean, the more advanced initiatives like the hypertension, diabetes programs had to stop because she didn't have the immediate physician backup. But she's continued doing the screening. Her funding is from the city for a hepatitis B navigator. So as long as that grant is going, she can continue.
Okay. Thank you. I think we have a few more minutes up. Rachel, your presentation brought to mind several things. In my experience, not many people refuse testing, and maybe others will have comment on this too, when they're offered HCV testing. I wonder if maybe all of you can comment on that, as well as people. I've often seen and heard about how some people feel more empowered, to do other things to improve their health with a cure for hepatitis C. Let me just start with you, Rachel, commenting on that, please.
Yeah, 100%. I think we don't get a lot of people who refuse, especially because we take an opt-out approach, right? So, okay, we just finished your blood pressure. Now we're going to do your HIV and Hep C test. It's just part of our routine with patients. Again, we try to take the stigma out of it, and making people feel like, oh, we're doing this because you have some sort of risk associated with it. We do this for everybody. This is a blanket thing. So we remove the stigma out of it. We don't get a lot of pushback. I will tell you, though, there are people who may be aware of their Hep C status. I had a patient actually, this just happened about a month ago, or less than that, actually. We were on site. He refused HIV and Hep C testing. I talked to him a little bit more about it. We were going to do some just general primary care screening labs, and I said, hey, I'll just add those on. At the time, he didn't mention anything to me about maybe previously being positive for Hep C at some point in his life. Well, he was positive for hepatitis C. We did the RNA reflexive testing, and I added some additional labs on so that we could get if he was positive, we could get him started on treatment. Brought him into the clinic for his regular follow-up and said, hey, you did test positive for hepatitis C. Oh, I knew I had that. That's why I didn't want the testing. I just didn't figure I could ever get treatment. Or I've heard in the past, I heard back in the day it was too expensive, or it makes you too sick. And there's a lot of myths around hepatitis C. And so I think part of that, urban legends that are still going around in the communities, keep people from wanting to get either the testing, because what's the point of getting tested if I can't get medication for it, right? So we see a lot of myth busting that we have to do still. A lot of people who are coming out of Department of Corrections often get told of their status, but they're not sick enough to get treatment, right? Because those are just protocols because of the way that our privatized Department of Corrections systems work, and being able to provide medications to, the people who are currently incarcerated. And so again, we have to say, well, you don't have to be sick enough to get treatment. I'll treat you today. And so, again, a lot of the people who don't want to get that testing, it's either a lack of perceived risks, the stigma, or they just already know they're positive and they don't think treatment is going to be an option for them. And so it's really about providing that, again, stigma reducing opt-out approach, and then providing education to be able to reduce that kind of like myth knowledge that, they believe is still to be true. The medication is still expensive, but we are able to help get you that medication at no cost, and we can show you how that process is going to be simple.
Thank you. I don't know if others have any comment about receptivity when you offer testing, and how people respond once they know they're being cured. I do like the idea about normalizing access to testing rather than always focusing on the risk, making it more of a routine preventive service in my experience, starting with our birth cohort approach years ago, just trying to say this is just good for your health without tagging it to a particular behavior. For me, seems to be the way to destigmatize this whole program. So thank you for that. I guess we're right up on time for our 90 minutes together. I want to thank you again for your work. You're doing great work all around the country. I'm glad we had an opportunity to showcase it for others to learn from it. I look forward to continuing to be connected to you, to follow along as you continue to build experience with these types of innovative programs, and to helping our country advance progress toward hepatitis B and hepatitis C elimination for communities that need these types of outreach services. So thank you again. And again, as a reminder, this information very, very shortly will be available in full on our website and YouTube channel. Thank you again, and keep in touch, and let's all continue to work together to eliminate hepatitis in the United States.